Hello, everybody, and a warm welcome. And important to note that we are recording this conversation on the 1st of December, which is obviously World AIDS Day. And maybe let me set the scene for our conversation. For decades now, the HIV story has been prominent in South Africa, but it still, I think, carries the heaviest burden. So while the science has advanced and the tools exist, I think it is fair to say that stigma still lingers. And perhaps more importantly than that, access to medication, to cure, is still uneven. And today in this conversation, I want to move beyond awareness and ask what HIV response looks like as we end 2025 and go into 26. And with me, two special guests, Rowen Govender, academic head at the Regenesys School of Healthcare, along with Stavros Nicolaou, senior executive for strategic trade development at Aspen Pharmacare. To both of you, a very warm welcome. And apt that we are recording this conversation on World AIDS Day. Stavros, let me come to you first of all. HIV awareness in 2025, what does it look like?
Jeremy, I think we're not doing as well as we ought to be doing for a number of reasons. I think firstly, we are seeing a significant slide back because HIV AIDS is not as topical as it used to be. It's to an extent been overtaken by non-communicable diseases, awarenesses around diabetes, cancers, etc., which are all very important. The second thing is there is an element of complacency that's crept in, and we're starting to see an uptick on certain demographics becoming infected again, and when we thought we had put the lid on it. And then I guess the third and most important reason is the geopolitics. So as other stories become more sexier stories like Ukraine and conflicts around the world, and as we are seeing significant donor aid cuts, that unfortunately has meant the last 12 months have not gone as well as they ought to have gone. So if you look at 2024, and we expect the numbers to be slightly worse, in 25, we had 53,000 deaths in our country from HIV. Now, it's a far cry from the 300,000
but
that
it's
we
still
experienced.
Significant, isn't it?
And the real risk here is we are not executing on our response, because you asked me about the response and what does that response look like. We are not executing as we ought to be, partly because of a resource issue from the donor aid cuts. Our response is guided by the 95 cubed, as we call it. So it's a target that the country has set, which is following the WHO target, where we will have 95% of the HIV infected population testing, 95% of those who test positive on treatment, and a 95% viral load suppression. So that's the target of the country. And if you follow that, you could eliminate HIV AIDS by 2035. But we're not achieving that, unfortunately. So there is a slide back. And the question is, how do we address that slide back, given some of the resource constraints that we're experiencing? But also, there are some very exciting new innovations in this field, primarily lenacapavir, which is an injectable form that you administer twice a year. And that could be the game changer in achieving zero HIV infection rate in South Africa by 2035.
Rowen, notwithstanding that figure of, I think you said 53,000, right? Still resonates powerfully. That is a lot. Do you think that complacency that Stavros mentioned has maybe set in because of a perceived sense of treatment success?
Yeah, no, definitely, Jeremy. And I agree with 100% with Stavros as well. Over and above the 53,000 that we currently do have about 7.8 million people infected with HIV in South Africa alone, which is a huge number as well. And for this year, in total, we had about 170,000 new cases that came about. So although this is far less than what it used to be, the concern around it is that people are a lot more complacent. But at the same time, a lot of people are just not educated enough around it. So we as a healthcare school, one of our goals is to basically try and advocate for this and try to ensure that everybody understands exactly what it means by these goals, which Stavros mentioned, the 95, 95, 95, but also try and understand or remove stigmas attached with HIV, which currently exist in the workplace, in the offices, wherever you basically go. We are trying to ensure that we now are not only advocating for HIV, but we are removing or destigmatizing what is known around HIV as well. Basic things around it, such as the U equals U campaign, which was run as well, which a lot of people see, but you don't really understand what that means. And basically, what that means is undetectable is untransmittable. And that is something so important to understand, because a lot of people think or perceive that if you have HIV, you will definitely transmit it to another person. When in actual fact, if you go on proper treatment regimes, lenacapavir, which is coming up soon, that would definitely assist in reducing your viral load to the particle and assist with preventing transmission of the virus.
Stavros, do you think public campaigns then are landing with the wrong audiences?
I think it's partly that, Jeremy, and partly the complacency factor, where you think, there's a common narrative that we're about to defeat HIV/AIDS, and that's, nothing can be further removed from the truth. So if you look at the demographics where there has been an uptick in cases, I mean, let's just mention a couple of those. Female sexual workers, men over the age of 40, for example, men having sex with men. These are some of what we call the vulnerable demographics. And that's why the lenacapavir discussion becomes a very important one. In my view, lenacapavir is probably the most important HIV tool and or innovation that we've had in the last 15 years. But the question then becomes, how effectively and how quickly and swiftly can we roll it out? There's a target price of $40 per annum that's been set. And I think we can get there as a country. The country's in the process of negotiating a license to produce it here in South Africa. And I think at $40 per patient per annum becomes very affordable. But more importantly, it will constitute the backbone of what we call PrEP. Now, what is PrEP? PrEP is pre-exposure prophylaxis. So that means you start using lenacapavir prophylactically. So it's preventative. It's almost like if you're going into a malaria-infested area and you take an anti-malarial ahead of the time, then you don't contract malaria, or if you do contract, it's very mild form. And the U campaign comes into that as well, because undetectable means untransmittable. And if we get it to that point where it's untransmittable, so you can still have patients with very low viral counts, but they don't transmit it. At that point in time, you can say you've defeated HIV/AIDS. Now, the projection is with the lenacapavir and the slide back that we've experienced, we could get to that point by 2035. And Jeremy, wouldn't that be a wonderful moment for the country and the universe? Because this is a universal issue. It's not just a South African issue.
It's predicated, of course, on whether we have the will and the capacity to roll out something like this. Do we?
Yeah. So, look, very, it can go either way with this. South Africa definitely has made a lot of advancements in terms of HIV awareness and treatment as well, with a lot of our institutes within the country actually working together to ensure that we eradicate the virus. At the same time, this goes to vulnerable communities, vulnerable groups as well. Stavros spoke about men who have sexual intercourse with other men or women as well. But also in terms of young men, we see a lot of young men who don't want to go and get tested. They fear actually going to a community work, a clinic, for example, who is going to actually see them, whether they will be exposed. They wouldn't mention these things to their workplace as well.
So and that fear is understandable.
100%. So this is where we as workplaces as well need to ensure that within that environment, we are creating safe spaces for them to come and say, listen, they have these types of issues, and how can we assist them with this as well?
But that's not happening at scale.
Exactly, 100%. So just in terms of, condom use as well, we have a lot of young guys who prefer not to use condoms. And unfortunately, because of things like this here, these are enhancing the transmission of the virus to vulnerable communities, to people who don't know better and are not seeking treatment as well. Within the young group as well, we see that a lot of these guys are not actually taking their medication as adequately as they should be doing so as well. So the hype is around actually, getting their first jab or actually taking their first pill, but afterwards they aren't basically, sustaining that measure which they should be doing as well.
So,
Yeah.
in terms of not only the rollout, but in terms of the educative side of it, what role, Stavros, does Big Pharma have to play in this respect?
I think, firstly, Jeremy, this requires what we call an end-to-end community response, and in fact, the challenges we're in the kind of the third generation of HIV in the country. If you take the early to mid 90s as the first generation, right? And these challenges are not new, but we overcame these challenges in the early 2000s. How did we do that? We did that by bringing in the whole of society. And that's where the SANAC was created, the South African National AIDS Council. And community NGOs have, and rightfully so, a disproportionate say at SANAC, because that's how it should be. If you get communities behind this campaign, it's the best way of succeeding. Now, what is pharma's role in all of that, and how do we intertwine campaigns and education campaigns in particular? What I find very effective is when you have community leaders in their particular communities holding meetings on the ground, that's at grassroots, and you don't need a doctor or a healthcare worker or a pharmacist, whoever it is, to go and deliver that talk necessarily. What you need is someone from the community. And there are these kind of toolkits that you can take. Obviously, you're not going to get into a sophisticated medical debate. I think what you're going to get into a debate on is, how do you mobilize a community? And if you mobilize community by community, that's when you start enjoying the success. And it's probably also not a bad moment to reflect on some of the successes we've had, because I remember those daunting days with those harrowing images where you get those population curves, and ours was mirroring. They were kind of mirroring a population where almost anything between 15 and 40 years old had been eviscerated, literally. And they were terrible graphs to look at. We've come a long way since then, and we've only done that because we've had community involvement, because you can have all the doctors in the world standing up on any single platform and saying, listen, this is what we need to do. But if you don't get the community buy-in, you're going to have a problem.
Providing that happens with a relentless and ongoing momentum.
Absolutely.
And it's back to your original point about the complacency. So how do you reignite it?
Okay. I think the public campaigns are going to be reignited. I think there's, as we speak here today, the Lenacapavir campaign is about to be rolled out. The country's received funding from the Global Fund, sufficient for around 470,000 patients, or 470,000 people will start getting Lenacapavir imminently. This is a donation from Gilead, who manufacture Lenacapavir. And with that is going to be a new campaign that gets sparked. Now, that's a campaign that's high level, it's all encompassing, and that's got to be pulled down to community level, as I say, for you to succeed. And I was just reflecting on the successes we have. We should never forget that we still have in our country 6.5 million people that every single day swallow a tablet for 365 days a year. Now, that's quite a significant achievement. It's one of the most successful public-private partnerships that we've ever carried out as a country. Of course, the donor aid cuts from the US is affecting that in some way, and we need to bridge that gap and bridge it urgently. And I think Lenacapavir could be some of that bridging.
What role then does an institution like Regenesys have to play, and particularly within the unit that you're running? How do you articulate the message more clearly, and what assistance do you bring to the process?
Yeah, no, thanks for that, Jeremy. I think it's very important to understand the gaps that currently exist as well. And where we see these gaps, we use that as an advantage because that's where we need to actually educate a lot more people around it as well. So the development of certain programs and courses around HIV awareness and management of the disease as a whole is really important. Simple terms that we probably use, both of us used here today, or which a lot of people just don't understand or haven't been educated about as well. So it's twofold. One is, as an institution like this, we want to actually impart that knowledge onto our learners, but also for our staff to create an environment here where they all feel comfortable to destigmatize it. And it's not one person's job to do it. As a community, we have to be able to do this. And the more we talk about this, the more we raise awareness about this, the more we actually remove all stigma that is attached to that.
Is there a different way that you're having to teach in order to get that message reinforced?
Yeah, definitely. So in the area of artificial intelligence, we are leveraging things like that to actually get our message across. We realize that a lot of students these days don't, take to certain learning styles. We need to tailor education to the needs of our students. At Regenesys, we have a lot of students who are part-time or distance students, which means that they don't have accessibility to a lecture on a full-time basis. Majority of them cannot even attend probably your webinars at specific times due to certain circumstances. So we are using artificial intelligence a lot to actually get our message across to students and realize that we're moving into an era where personalized medication is becoming a thing. So if you're looking at the genomic structures of individuals in South Africa, and if we're looking in North Africa as well, these are types of informations which artificial intelligence would be able to pull so that we can teach students in a certain way, but also deliver and administer medication in a certain way.
And Stavros, is there a symbiosis or a synergy between a company like Aspen and Regenesys in order to make sure that that message is more strongly reinforced?
Okay, there most definitely is, and it's not the first time either that we're working together. I think there are many social and socio-economic challenges I think that confront us, whether they're in public health or they're in the economy or GBVF, whatever it might be. And I think an academic institution that has quite a wide reach like Regenesys, I think is a very effective way of communicating messages. But you're also going to have inevitably, if a student here, undergrad or postgrad, is educated on the subject matter, they will automatically transmit that to many, many others in their communities. And I keep going back to the community response. And very often, academia is a leader in any community. And I think that's the role that they play. So there's definitely a synergy. I think the other synergy that we ought to be speaking about is we've got a duty to educate the general population that if we are to slide back to those haunting days, and they were haunting.
Sure.
I was very involved in the early 2000s, so I'm giving my age away here, but those were harrowing days, far worse than anything we ever encountered during COVID. Now, the economic impact of that, if left unarrested, and we're kind of just starting to sow little green shoots in our economy with some of the latest news. You don't want to start sliding back economically or from the burden of the public health demand that will come from this if we leave it unarrested.
As I said at the beginning of this conversation, we are taping it, recording it on World AIDS Day, which is very apt. If you could implement one practical step, then, and it's a question to both of you, in the very short term, in order to arrest the problem and give us the impetus that we need, what would it be?
I think a more aggressive rollout of both lenacapavir and antiretrovirals, because not everyone.
What does aggressive mean?
Aggressive means that if we've got 8.5 million people on that are HIV positive, that you get all of those people on treatment, and that you ramp up the pre-exposure that I spoke about, the PrEP that I spoke about. If you get that right, then it is quite plausible and feasible in our lifetime that we will see the end of AIDS in our country. And boy, won't that be a remarkable and joyous moment.
Something to celebrate. Rowan, what about you?
Yeah, I think innovation cannot surpass practicality. And as much as we're trying to be innovative in our approaches, the reality within South Africa is a lot of individuals do not have access to basic healthcare needs. So providing that access, and again, vigorous campaigns around access, around educating and knowledge for everyone, whether in rural or urban areas, is extremely important. So a lot more campaigns around that would be very much useful.
I think an important and an elucidating conversation. To both of you, thank you very much.
Thanks
and
very much for
thank
having
you
us.
for watching. Until next time, goodbye.